So let's discuss what's new in the 2024 Kawasaki Disease American Heart Association scientific statement. So point number one is that the diagnosis still remains clinical. There are no clear-cut biomarkers to suggest Kawasaki disease, and it's a diagnostic criteria. So they have to fulfill 4 out of the 5 criteria. We know the red eyes, the red tongue or strawberry tongue, lymph nodes, rashes, fevers, etc. Number two is the imaging part or the echo. Now, echo is very important, especially in infants, because the risk of coronary artery aneurysms is significantly higher. Now, initial echo may be normal. It has to be done by a pediatric cardiologist. We have to calculate Z scores, and the Z scores have to be calculated by the same method every time. And ideally, it has to be the same observer, same machine, same Z score every time to be able to compare whether or not the Z scores have worsened or not. Now, the next part is the treatment part, and the first part of that is the high risk children. Now, high risk children need early primary intensification, which means they may need dual therapy. So, for instance, IVIG with the steroid combination is IVIG plus steroids plus low dose aspirin. Aspirin dose, again, they have reiterated that it's not very relevant in the coronary artery outcomes, whether we use high dose, moderate dose, or even a low dose. So we don't really have to get very emotional about the dose of aspirin. But the main thing is, what anti-inflammatory or immunomodulator are we using? Is it IVIG? Is it steroids? Is it cyclosporin? Is it infliximab? So in resistant cases, we would use the other options, for example, infliximab or second IVIG or cyclosporin or anakinra, etc. The new conversation which has started coming up in these guidelines is around the direct oral anticoagulation or DOACs, such as apixaban. Now, for children with giant aneurysms, we've been using triple therapy, which means dual antiplatelet and one anticoagulation, which usually is the low molecular weight heparin and warfarin. But the problem is the monitoring and the frequent injections. Now, there is more and more data that direct oral anticoagulation can also be used in some children when they need long-term anticoagulation prophylaxis.